Thank you all for coming. You're clearly all pleased to see each other, particularly Grant there. So it's our pleasure today to welcome Professor Neil Osheroff to New Zealand. So Neil comes from Vanderbilt University, and he is a distinguished medical educator. He is also a distinguished biochemist. It can be difficult for scientists who work in the ALM program to essentially get enough teaching time to get permanent positions and have career progression. So one of the things that Neil's going to be talking about today is about his experience in actually being a scientist in the medical curriculum. So he is a distinguished educator. He's past president of the Association of Biochemistry Educators and is currently treasurer of the International Association of Medical Science Educators. He was pointing out before that being a teacher means that this is going to be a good talk.
That doesn't necessarily apply to me.
Pressure on Neil. So I'm looking forward to hearing what he has to say. I'm sure that he can fill you in on anything else he'd like you to know about himself. So I'm just going to hand over to Neil at the moment. If people are here virtually, if you just type in questions into the chat box, I'll be sitting in the front here and we'll be monitoring it. I'm sure this will turn into a conversation.
Well, good morning. It's lovely to be here. We have a small group and I like to wander, so I would hope this will be more of a discussion than a lecture today. I will be talking, I guess, at 2 this afternoon about curricular integration. One of the things I wanted to do this morning was really focus on what are the effects of that curricular integration on individual faculty. Now, real quickly, are there scientists? Are we scientists? Are we clinicians? Mostly scientists? Okay, so that's good. So you can identify with some of the things maybe a bit more strongly. I want to work under a premise today, and the premise is that 15, 20, maybe years ago, we were what I would all refer to as medical teachers. When I get to Dunedin, I'll say basic science teachers, but I didn't know what I had here. And over the years, we've now become what I would now call an educator. And this is the premise, and we'll talk about what that means, at least to me. Also, the idea is that the transition is driven really by curricular integration, taking us away from individual departmentally based courses. And so what I want to do is kind of compare and contrast, at least my vision of what a teacher is versus an educator. I wanted to talk about what I consider the roles of the modern educator now and discuss how these changing roles have really opened tremendous opportunities for people involved in medical education. All right, so back in the day, and this goes back at Vanderbilt to before 2007. It's still the case in many institutions in the world. There were siloed basics. They're discipline-based courses. Still that way, certainly in the clerkship phases and then the clinical years, but in the basic sciences, go back to the days when there's a biochem course, pathology course, pharmacology, physiology, completely siloed. As I like to say, the only integration I had with anatomy, because we were the first course, and we were Monday, Wednesday, and Friday biochemistry, Tuesday, Thursday was anatomy, and the only integration we had whatsoever was before the first lecture happened, the head of anatomy would send one of the underlings over to my office and say, here's when our exams are going to be, don't put yours too close. And that was the degree of integration we had completely. The vast majority of educationals we had were lecture-based. There would be maybe 1 hour of token something a week that wasn't in the lecture hall. And the vast majority of assessments were all multiple choice. Okay, so when we go back and talk about teachers, what's your vision of a teacher, quote unquote, by the modern vernacular? Anybody? Somebody? Okay, role model. What else? You're thinking more modern. What about the old days? What did a teacher do? Impart knowledge. Basically, they sit in front of a lecture hall, right? And that, to a large extent, was the role. We stood in front of a lecture hall. We maybe put the course together, and that was about it. And so what I really want to talk about is where we were then and how it's really changed over the years. I think in a very good way. So, okay, how are these teachers and course directors, people with authority, chosen? And there were some very good reasons based on their skill sets. You're usually a very good lecturer, enthusiastic, you're passionate, at least you were not as unpassionate as some other people in the department for teaching medical students. You're well organized, you're clear, and all these things is interesting because depending where you are, faculty will tell you that the well organized and clear are the most important things of a lecture. The students will talk about enthusiasm and passion. There have been studies done on that. One of the worst things that a medical student can say about Dr. Osheroffs' lecture is he acted like he didn't want to be there teaching medical students. I see some smiles, okay. Either you're well liked by students, or I'm a biochemist, so I would say I wasn't as disliked as some other people might have been, because you have no idea. You have any biochemists in the room? Okay, you have no idea how many times I've met physicians. They say, "Oh, I hated." First thing they say is, "Oh, I hated biochemistry." Yeah, I see nods. But anyway, all these kind of things we're talking about, these are good, and these have a positive impact. There's nothing wrong with them. There are also some not so good reasons why people were chosen to be course directors or being heavily involved in medical education. Okay, if you're a basic scientist, you lost your funding. Neil, we got to do something with you. You're teaching my med course. I could have been a great lecturer. I could have been a terrible lecturer. You need more teaching time for promotion. Once again, however good you are or bad you are, it didn't matter. Your turn to run the course. You had it for the last 3 years. It's my turn now. Or no one else would do it. And so these are reasons that, you know, didn't have a positive impact necessarily. And I talked to groups of basic science chairs. There are national organizations in the US where the biochem chairs, the physiology, the pharmacology, and things like that, they go off and have the retreats, usually in very posh, interesting places. And to be honest, even 5 years ago, many of them saw all the people that were doing the teaching, especially involved in leadership roles, were interchangeable. Because if you couldn't do it, you could. And also as a result, certainly in a basic science department, at least in the US, if you're in a research-based medical school, if you don't run a research laboratory, you're at best a second-class citizen. You're someone that's not really on the radar screen, and you're not as important as you might be. Hence, not a lot of respect. And even today, I mean, I've run a full-time research laboratory, but every time I get together with my chair, at the, have our yearly chat about how my career is going, he always asks about education. And I say, well, we want to hear about what we're doing in lab. And he goes, oh, Neil, I know you're teaching so much. And it's like, I got a wall full of papers. We're doing fine. And then he keeps telling me why he doesn't expect me to do anything. So nonetheless, so teachers kind of get put in the cubbyhole. Okay, they can. There have been a lot of ramifications of the modern integrated curriculum. There's a lot in here, and I apologize for it. But at least in the US, most schools have gone to some sort of integration. And there's been a really seismic shift in the last decade. The first meeting of the Biochemistry Educators Association, Association of Biochemistry Educators, was 2008. And there, the big discussion was, do we have to do this? Why are we doing this? And now it's just taken for granted we've done it. In an integrated curriculum, undoubtedly there's less time to teach biomedical sciences, also sometimes clinical sciences. So we have to teach smarter, we have to prioritize what we're talking about. There are changes in the way we teach and the way we assess, not nearly so much time in front of a classroom as it is facilitating smaller groups. We do assessment very differently now. It's not all multiple choice questions. One thing that was really a seismic shift, we had to work in teams. And that doesn't sound like that difficult these days, but the first time you say, Neil, you've been running a biochem course for 15 years, and this person over here is running a histology course for 5 or 6, this person's been doing stuff with genetics, sit together and you have to plan a course together. That was a side, the earth trembled underneath us. And by the way, only one of you is going to be course director. So that changed identity issues totally. So that was actually difficult. Also, now you're dealing with clinical mates and everyone else. So this was a real big shift for us. The other thing is that there's a centralized curriculum now. Someone has to figure out how the pieces fit together. Before it was like, okay, biochemistry is teaching in the fall semester, anatomy is in the spring, it was physiology, and it was microbes and immunity. But now someone has to really, it doesn't go to the individual departments anymore, it goes to a centralized curriculum. And in many places, the staffing and the approval of topics no longer controlled by departments. That's another thing that's been a really big shift. And the other thing that I try to convince chairs of is that they're no longer in charge of the curriculum in most places. It's people like myself that really are in charge of the curriculum. So they have to have really well-trained individuals that really can be banner bearers for what basic sciences should be. So what I would postulate is that in a discipline-based curriculum, medical teachers are playing an important role in the department. I had a perverse position of power, as I like to call it, in that I had the one job in the biochem department of Vanderbilt that no one else wanted. It protected me in many ways. Anytime anyone was interested in me leaving Vanderbilt, there was a line outside my chair's office saying, if Neil leaves, I'm not doing this. It got me out of doing a lot of other things. I never had to be director of graduate studies in my department because this was the only job people hated more. So from that point of view, you had this odd position that you had real relevance in your department. You also kept the medical administration off your chair's back. So they're very happy for you for that. I figured out pretty early that once we had integrated curricula, your interaction with the department were going to change dramatically. Because now there's no such thing as a biochem course. So, okay, at Vanderbilt, if I leave, my chair doesn't have to replace me. No one else is responsible in my department for doing things. And in many respects, the departments, one bad thing is the departments have become somewhat disenfranchised from medical education. They no longer had it on the radar screen. Chairs in the US are terribly more worried about grant funding and other things like that at this point. So basically, your relevance to the department kind of went away. That being said, your relevance to the School of Medicine became dramatically more important. And at least at Vanderbilt, our administration really had a good look at who the people were who really were educating their medical students, right? So this became really important. How many people here have deans in the title? Anybody? A couple, okay, a few, all right. So I would hearken to you people that, you know, if you're not already doing it, and I think you are, but really pay attention to these individuals because they don't necessarily feel like they have a home sometimes, and it's really critical for them to be able to perform properly. All right, so here's my premise. That new responsibilities and relationships with departments in the university come through the curricular integration and this transition that we've made as educators. You need a vastly larger skill set, and we'll talk about that, required for medical education than in the past. Before, you had to stand up, give a good lecture. Didn't know how to use PowerPoint, and you had to put things in a projector, maybe use an overhead, whatever. Now there's a whole lot more you need to be able to do. And as a result, I think it's more important than ever to be able to define ourselves as educators as compared to what we were, and to define the essential roles. So then my question is, who are you? Who are we? For the people toward my generation, who have I got up here? The who, thank you very much. For the younger, do you guys get Crime Scene International, Crime Scene Investigation in New Zealand? All right, so that's the theme song to the CSI, all right? So for the really young ones in the group, maybe, even that, they're in reruns now. All right, yeah, I thought of it the other day and I figured, okay, I can identify with these guys. They look old. So there's a bunch of people out there to define it. We don't have to do this all on ourselves. There are, if you look, there are national bodies. So there's AAMC, the Association of American Medical College in the US, New Zealand Medical Association, CanMeds in Canada. There are educational organizations like IAMSA, the International Association of Medical Science Educators, Association of Medical Education Europe. There are academies, so the Academy of Medical Educators of the UK sets standards and roles for medical educators. I chair or I direct our Academy for Excellence in Education at Vanderbilt. We've done similar things. There are books, this latest one by Ronald Harden and Pat Lilly on the 8 roles of the medical teacher. So let me get back to a question I asked before about sort of what we were, what we are now. So so we've talked already that you're a facilitator of knowledge, you're an imparter of knowledge. What were the other, now when you think about a medical educator, what are the roles that come to mind? None. Come on now, got to be like students. You what? Mentoring is an important role. What else? What else do we do as educators these days? You can do research in it. You can certainly do. You can do medical education research, right? And you can be a scholar as a result. Anything else? Okay. Inspire and motivate. Excellent. They claim that the best teachers, that's what they do. Other things? All right, let me talk about what I think some of the roles are. And these get put together in various forms. They all come out sort of the same. And let's talk about them a little bit. But the other thing I want to do is, while we're going through these, is also talk about how these have opened up opportunities. Because one of the things that's really happened is curricular integration has really messed, if you will, with the identity of educators. I went to a workshop on sort of identity. And one of the things I realized is that if you ask me who I am now, I would tell you, first, I'm a researcher, because I've always been a researcher. The second thing I would tell you about is my educational efforts. 15 years ago, I would have told you I was a researcher, and that was it. Because despite the fact I was doing a lot of teaching, I probably had more, maybe more face time then than I do now, because things are so much more heavily based in lectures. That was part of my university service. I didn't really see that as imparting, if you will, worth to my career or to me as an individual. Today I see that vastly differently. So these conversions have really taken someone that knew what they did. I run the biochem course, I stand up, I give good lectures, to now I'm involved in something and I may be a thread leader, I may be something else. I'm not really sure what I am anymore. You don't want me to give as many lectures anymore, so what am I? So let's kind of talk about the different things we can do. First is information provider, right? Came up before, teacher, but also facilitations become incredibly important. So that now, okay, you still give lectures in many places. There are some schools in the US that are happily writing that by 2020 they're eliminating all lectures, and how great that is. I don't particularly think it's anything wrong with lectures as long as it's a good lecture and you don't lecture for 20 hours a week. At Vanderbilt, we see each educational modality as having its own strengths and weaknesses, right? So that flipped classrooms are another one now. So where the students, now you say, right, why should I tell you knowledge you can read online? Go read the things online and then come and we'll discuss it. And that's okay. A lot of places use it. They really abuse the students by doing this. I used to have 12 hours of lecture. I only have 6 now. So I want you to go home and watch my 12 hours of lecture, and then we'll come and do another 6 with me. But once again, this more facilitation, things like just-in-time teaching. We see what the students know. And I'm happy to leave these behind, by the way, people taking notes. If you want, Diane, I can leave my slides behind. Distribute them, feel free. So just-in-time teaching is when we give you a little quiz on what you've studied. Now I know what you know and what you don't know. We can talk about it. Team-based learning, we do team-based learning here, right? And we do problem-based learning. We call it case-based learning, various different things. So there you're really much more of a role of facilitator. Sometimes it's keeping out of the way of the students. So a lot of small group facilitation, giving feedback now is an incredibly important part of our role. Online learning has become really important. We are broadcasting to Christchurch. Okay, so people can be home watching your lectures and things like that, and how to put things online. It's very different. Learning objectives versus goals, right? We've had to learn what learning objectives are and what different goals. And what I'll call active learning versus engaged learning versus passive learning. So for me, active learning, by some of the definitions, are students have to set their own learning objectives. They have to figure out what they want to learn, what they need to learn. Engage is when we say, read this article, we'll come back and we'll talk about it. They're there, they're talking to you, but they're not really setting their own learning objectives necessarily. And then passive learning is potentially what we're doing here, but try to make it as interactive as possible. And once again, so if you think about it, okay, on the one hand, you can say they're taking away my lectures. The other hand, facilitation is an art unto itself. And actually, small groups we work with at Vanderbilt, I'll talk to you about later, are really remarkable. It's really fun to watch the students engage in this process, and you can help direct it. So once again, opens up more opportunities for teaching, but in different ways. Assessment has become really, really critical in most schools. So there's formative versus summative. So formative is, I'm just giving you this, telling you about how you're doing to make you better. Summative is, I'm doing that too, but I'm also putting a grade in for you. Item writing. So how many people are used to see multiple choice questions that went something like this? Which of the following enzymes is not involved in carbohydrate metabolism? And a list of things, right? Yeah, we can't do that anymore. Most questions now start with clinical vignettes. Someone walks into a doctor's office with this complaint, and so they have to think about the clinical reasoning that takes them back to the answer for their questions. We do a lot of essays at Vanderbilt, and people usually go kind of wait when I tell them that. Here you have a class size about 100, I guess you're the best same size we have at Vanderbilt. My block last year, I graded about 2,200 essays. Now you go to a school like St. George's in the Caribbean, and they have 2 classes a year, and the first class comes in with 800 students. You use the word essays around them, they go ashen. Doesn't matter how much sun they've got, they go pale. But essays are a way to test deeper knowledge. There's a whole thing about assessment strategies and validity, so statistics and psychometrics that very few of us actually fully comprehend, I'll be honest. We'll talk a little about competencies later today. So there's competency domains versus competencies versus milestones. These are languages that get interchangeable and not appropriate. Remediations become vastly more difficult in integrated curriculum. It used to be, if you failed my course, there were 3 or 4 places in the US you could go take a summer school course in biochemistry. That was okay. You can't do that anymore. And program assessment overall, which is something I think we never really did. We looked at individual classes, but never the program and how we're doing as a program. And once again, opens up a lot of doors for people to work in different areas. And we'll talk a bit more about them when we get to leadership. Mentoring. So, okay, what is mentor? I mean, mentor, where's the name mentor come from? Anybody know? Mentor was actually a person. What? Hold in mind, but mentor was a person. Mentor was a friend of Odysseus. When he went off to the Trojan Wars, he left a mentor in charge of the education of his son Telemachus back home. And that's where the word mentor comes from. So they're mentors, and we know what mentors do, right? We're advocates, we push, we help direct careers. And you can also argue that there's a current vernacular for the term coaching, which is different, at least in the US, because a coach is somebody that looks at what you're doing and can stand back and take a more objective view than potentially a mentor can. A mentor certainly is caring and can do the same thing, but the coach is there to really say, all right, this is what the faculty is saying about you, here's what you're saying, and I'm not saying these things go together, so let's talk about how to get past that. And the other question is now in this day and age, who are really the mentees? So the mentees are students. Who else are being mentored? Other faculty. Faculty development is huge these days in more modern curricula. So once again, tremendous opportunities, and it goes back and forth. I've had students that I taught when they were graduate students at Vanderbilt, went on to become president of the American International Association for Medical Science Educators. So as I was rising in the organization, they were mentoring me. I'm mentoring them about career things. They're mentoring me about organizations. So mentoring and mentors and mentees can be fairly fluid as well. Okay, so now, basically, I think it's safe to say everybody in here, if they're teaching a session, designs their own session. How many people run courses? Okay, several of you. So, okay, so that's another skill that you're running courses. How many people are in charge of a phase of medical school? Right, we've got, so it gets narrower, but once again, more things come out. Back in the day when we had a 2-year pre-clerkship curriculum, I don't think anyone was in charge of it. I mean, that went to the dean's office, but there's certainly not a faculty member that was charged with figuring out what the students need to know. So once again, now you have presumably administrators, but also faculty in charge of figuring out what the students need to know and how it's being put together. Overall curricula is there are people who are in charge of that. But now there are other educational programs. There's the teaching, how do you do faculty development, teaching the teachers. Apps, there's some apps coming out of Vanderbilt they're very proud of. Learning environment is a really big deal in the US. And I think that when we were at ANZAPE, something came up about, I believe you had the phrase of the toxic learning environment in the US. Yes, that still rings in my head, which it can be. And there's also, but you can do these things locally, but also you can do them nationally or different schools and even international. So let's talk about potential for leadership roles. One of the things that's really amazing to me is in these new integrated curricula, faculty have vast opportunities for leadership as long as they embrace what's going on. So at the local level, one thing of the things we talked about, you can be running a course, you can be running a year or phase. There are various people involved in curriculum. Deanships are bound these days, at least in the US. There's deanships all over the place. So once again, tremendous opportunities for someone to step in and be in charge of the curriculum or biomedical sciences or clinical sciences or assessment. We have deans for all these sort of now. Is the academy movement down in Australia and New Zealand much at all? Okay, so does Otago have an academy of educators of some sort? Okay. Nationally, or this is school? Okay, very good. But do you actually have an academy here? Okay, all right. So Vanderbilt, think about 2007 or so, came up with an academy. These are, depending how it's used, these are communities for the educators. One of the things that's nice is historically, we were all kind of out there on our own. first time I went to the meeting of the Association of Biochemistry Educators, which at the time was the Association of Biochemistry Course Directors. But then we realized that there were virtually no biochemistry courses anymore, and people weren't coming to the meeting because they said there had to be a course director to come. The first time I went to that, my chair came to me and said, Neil, there's this thing they're putting together under the guise of the biochemistry chairs, the Association of Medical and Graduate Departments of Biochemistry. Said, you ought to go to this meeting. Now, he didn't offer to pay for me, but he sent me to the meeting. And whereas the chairs were going to places like Guatemala and St. Kitts, and they're going to Quito, Ecuador, with a side trip to the Galapagos next year. When they stay in the US, they go to Kauai or Maui. They sent us to Myrtle Beach, North Carolina. If any of you have ever been to the US, Myrtle Beach, North Carolina, it's an okay beach, but it's not Maui. Let's just say that. It's not even Kauai, not even Quito. I mean, what the heck? But the first time I went to that, it was really fascinating for me because I realized I knew about half a dozen people in the room, and for the first time ever, I felt like there were other people that understood what I was going through. So these communities are really, I think, kind of important. And for example, as I direct our academy, and I've been able to kind of change the emphasis of it. It used to be an academy for excellence in teaching. But the problem was that there are a lot of people who are involved in education these days that don't stand in front of a classroom and do what I'm doing right now. So there are people in charge of assessment and the learning environment and curricular design that aren't doing a lot of stand-up teaching. And I had to have a discussion with the chair of psychiatry at one of our meetings where he boldly said that he did not see facilitation as a form of teaching, and therefore people should never be promoted based on this. So that it was really fascinating to have a group together for the first time that you felt a kindred spirit with. There are a bunch of things. So for the scientists here, there's an entire parallel universe of medical education. And all the things that the scientists certainly prepared to do, which was to give talks, to write posters, write abstracts, network properly, handle yourself at a meeting. It turns out there are a lot of educators there who have no idea how to do this. So I'll say to the scientists in the group, these are really easy for you to go to and get along very, very well. So they're discipline-based organizations, so based on whether you're a pathologist or a biochemist or an anesthesiologist. There are sort of more general ones, which would be IAMSA is one, Association of Medical Educators in Europe is another one, ANZAPI obviously is one. So there are a number of these that I think are really phenomenal venues. And then there are also national medical education journals. So Academic Medicine in the US, Medical Teacher, which is out of AME, Medical Science Educator, which is out of IAMSA. So if you think about it, now, as a teacher, quote unquote, my opportunity was to teach in my course and run a course, and that was about it. Now, as a medical educator, in addition to doing those, I co-direct, well, I was one of 4 faculty I'll talk about later today that were directed with, or were tasked with developing and implementing our pre-clerkship phase. I now co-direct the phase. I've got leadership in that realm. I still run a block. I direct our academy. I do things at the national and international level now, all because I'm an educator. So there are tremendous opportunities that go along with the title and with the responsibilities. Then they get to scholarship. It depends how this is broken down. Sometimes this is put as a separate category. Sometimes this is put as evidence that you're doing well in the other categories. But the idea that faculty development goes under this. At the very least, being able to apply educational theory and best practices in your own personal teaching and how you can take feedback and developing it better. But to some extent, you need to be able to inform others about what you're doing. So you need to be able to publish or do things, go to meetings, network, and do posters, talks, and things like that. Publish your findings. In the world of science, it's really defined as what scholarship and publications mean, right? They mean peer-reviewed papers. Hopefully in high-impact journals. That's, oops. Okay. Got it back. There are places where those metrics really matter, where if you publish in a journal with impact factor over 15, it does this for your career versus when this 5 does something different. In the education world, the vast majority of us don't actually do medical education research. I mean, there are people that do cognitive psychology that really do research in educational theory. Most of us don't do that. When we write papers, we report in the kind of programs we put together, what we're seeing in our classrooms, or we come up with ideas. that kind of look at for the students. So if you're running a laboratory, you may be expected to publish 5 or 10 papers a year. And for the vast, vast, vast majority of us in education, there's no way possible you can really do that. So in the world of medical education, papers are still the gold standard, but I think attending meetings, giving workshops at meetings, focus sessions, giving talks there, even down to posters, is for the most part considered medical educational scholarship, which creates a problem because that means you have to be able to get to those meetings. So I have a number of colleagues at different schools that are well known, but they get to go to a meeting once a year, once every other year. So when I write letters on their behalf for promotion, and one of the things that seem to be lagging are by the classic metrics of scholarship, I will usually write their administrators and say that they could do more, but you guys aren't allowing them to. So that's a problem. You need to be able to send people to meetings to be able to do these things. All right, so what I would say, and we can discuss afterwards, because this is a short talk. The one in the afternoon is more classic hour-long kind of talk. But I would say that the role of the modern educator really requires just now a unique set of skills that extends way beyond departmental or school of medicine service. So one of the things, like I said, back in the day, you needed to be able to give good lectures. Now you need to be able to do a bunch of other things if you're going to have any kind of leadership role in education. The other thing that's happened is there's been a pretty bad split. When the Association of Biochemistry Educators started in 2008, remember one of the chairs that was there said, out of curiosity, how many have sort of national level, what we call R01 level support, NIH support in the US? And maybe about 40% of the people raised their hand. There was what I refer to as a citizen soldier. You ran your lab, you taught your course. The last meeting, it was less than 10%. Two things have happened. Grants have become vastly more difficult to get and to keep. So that's, anyone who was sort of doing okay in research, they're kind of gone now. And the other thing is that there is an entire skill set that needs to be learned to become a high quality medical educator these days. So the amount of work you're doing and the process to get there is much more difficult. So as a result, and I'm not terribly happy with it, but we're starting to have a split of faculty, at least in the science world, of those that do research and those that teach. And I don't like that. There are certain people in this day and age that almost have to be professional teachers, that very few people, at least in the medical realm, are still doing research in anatomy anymore. There are schools where it's the cultural anthropologists who are actually teaching their anatomy these days. They know anatomy phenomenally well, but they think about it from an evolutionary point of view, not from a disease point of view. I would also argue that because of this position of medical educator can't be easily filled. People are not interchangeable anymore. It provides genuine value back to both the department and the School of Medicine. So I personally believe that the modern medical educator is vastly more important to their School of Medicine than they ever were as a teacher that was in a siloed basic science department or medical department. But I think there's a payback. So when you say, okay, we're a lot more important, you need people with more respect, at places like Vanderbilt now you can be promoted in the educator track. The only people that can get tenure at the university are on research track, but you certainly have opportunities for promotion now. I think what we have to get back, if we're going to say, all right, you need to respect me and there are all these things I can do, I think you have to say, all right, now I have to be more than someone that simply stands in front of a room. So someone that simply stands in front of a room, that's great, but I don't think it's going to get to promotion anymore. I think that to get promoted, it's becoming more and more important to have scholarship that goes with it and some leadership roles that go with it as well. So I think that's something that we owe back to people to say, if we see ourselves as more important, then we have to act in a more important manner. We have to do things that are higher level in order to be able to be promoted. So I'll kind of leave you with this. I think that this evolution from being someone that stood in front of a lecture hall to someone that is multifunctional now and does a lot of leadership and other things, I think it's a difficult process. It's got to be deliberate and it requires a lot of work. I mean, you just don't stand up one day and say, I'm going to do all these other things. It takes a lot of development. It takes a change in your identity because now you have to think of yourselves differently. And I know I certainly have over the years that I am vastly, I wouldn't say I wasn't proud of what I did before, but it didn't register. Once again, it was something I did because someone had to do it. You ran a core, you did something else, I taught. And that was the way I really saw it. Now I see being a role of medical educator as being vastly more important. And I'm immensely proud of the things I'm doing, the things we're doing at Vanderbilt. So that change in identity thing is an interesting thing. It's hard. but it can be, I think, really rewarding and offers really bright educational and career opportunities, so that when people felt they lost their way because now I don't have a course anymore, what am I going to do? Literally, one of my colleagues that we were co-designed the pre-clerkship phase, we met every Friday afternoon, 4 of us for 2 years, putting the phase together. And almost every Friday as we were walking back to our offices, her eyes would get glassy and she was terribly afraid that there was no role for her in the new curriculum. She's now the assistant dean of a medical school assessment, and she's got more things going. She's a linchpin of really of the pre-clerkship phase. If she goes away, we're going to have to find about 5 people to replace her. And so I think that there are tremendous opportunities that come along with it. The other thing I will point out, there's a wonderful quote that I always thought came from Machiavelli, but it turns out Sun Tzu is, in the midst of chaos, there's also opportunity. So that curricular revision is really a chaotic process. There's a ton of things going on. I think what people need to think about, instead of, at some point it's going to happen, and instead of trying to fight it, embrace it, figure out how to do it well, and you'll make yourself invaluable to wherever you are, but then the other possibilities just really open up. So there's tremendous opportunities when your medical school curriculum is in flux. That's the time, that's really the time to step up and think about ways to make it better and ways that you can do it. I think you help your institution, I think you help yourself tremendously as well. That's all I've got to say about this. Do you guys want to talk about it some? I'd love to hear your impressions and your thoughts, and where I've gone astray, where you can help me, or things you like or don't like about what I had to say.
So can I talk to Kirsty here? Kirsty and I were having a discussion just before the lecture began. There was a pathologist and a scientist talking about at OSCE and explanation and planning. We were talking about how to teach med students clinical skills. So I think this is a really good example of the journey that Kirsty's been on since she's been here, haven't you? Could you imagine 5 years ago, we'd have been having a conversation about how to examine clinical skills in medical students?
So you said a pathologist and a scientist. I thought pathologists were scientists.
No, I'm a doctor.
Well, yeah, but
not necessarily scientist.
Okay, fair enough. Fair enough.
So I wondered if Kirsty, maybe you could talk to the people in the room who are just starting the journey here, because we've got some people who are PhDs and are on soft money in the room. And what would you say to them?
Okay, I don't really know how qualified I am to talk to this just yet. So I've only been teaching in the medical school for just over 2 years now. Very much science background, cell and molecular biology. Never thought I'd end up teaching in a medical school. But so I guess I've ended up working a fair bit in the assessment side of our students, so on OSCEs. And the other thing I do is I do some lecturing and workshops with the students on things like tumour markers and things like that. I definitely made the mistake at the beginning of my teaching of trying to teach too much from the science perspective still, whereas now I changed it all around and flipped it, so it's basically talking to them actually from the point of view of medicine, and then almost I feel like you sneak science in and sort of trick them into learning it. Yeah.
I think part of the key is you don't have to call it basic science.
Yeah.
I mean, I think if you teach in the context of the patient, I think it becomes vastly easier. And I'll talk about this in the afternoon talk, but really the question is, why is your patient sick? Tell me about the disease they have. How are you going to treat your patient? Why are you treating them that way? And that's all foundational sciences. But you don't have to call it biochemistry. I mean, no one wants to write the Krebs cycle on the board, but a lot of these things go back to, fundamental pathways and metabolism and other things. So that, yeah, I think you don't have to be embarrassed about, sneaking it in, but you just have to call it something different. Yeah. It really is true, because I mean, no med student wants to learn things that they don't think are relevant to their career. I've even told my students, if you say to me, okay, Dr. Osheroff, I didn't do well in this part of the exam because I made the conscious effort. I thought about what you were teaching, and I thought that had no relation to me being a physician. So I decided purposely that I was not going to waste my time studying it. I can tell you you're wrong, but I'll respect your decision, because I mean, that's one of the things they need to do. They need to filter. So if the student actually told me that, I would actually respect that. I might just tell them why I think they're wrong. But I think that's okay, because that's one of the things we're asking them to do now. So yeah, I think that one of the things you hate to hear from a med student is, oh, that I didn't come here to be a PhD, right? And we're not trying to tell them that. We're trying to teach them how to take care of a patient properly.
Yeah.
So Kirsty's head of department, head of surgery, is a scientist. So he sees it's okay for scientists to teach medical students and not just teach them science, but teach them everything.
Absolutely. I mean, one of the things, well, in the US, I think I've been saying this for a while, but there seems to be a movement. We don't talk about the preclinical curriculum anymore. Because, I mean, how many of you are still teaching in the quote unquote basic science here? Right? Are there any basic scientists here that don't have something with clinical medicine in their courses? And the answer is, I think, none. So we're teaching a ton of clinical medicine early on. We refer to it as the pre-clerkship phase. It's the clerkships when they're actually doing their studies, the first studies in the wards.
So the people who are like new on soft money, what is the most important skill do you think they have to learn in order to become a medical educator and actually start teaching?
Well, okay, for one thing, we're at Vanderbilt. I think I have a guaranteed position. I'm tenured faculty. I have a guaranteed position. I don't necessarily have guaranteed space or a guaranteed level of salary support. So actually, in the educational world, that brings in about 45% of my salary. So from that point of view, that's actually almost hard money for me. I think some of the most important skills are the interest in doing it. I think there are very few people that are fatally flawed that can't be an educator. Usually ones that don't want to try. I mean, there are lousy lecturers out there, but just because you're a lousy lecturer, you may be a marvelous facilitator. So just think about how you want to get involved. And as I said, now in the realm, we have, it depends where you go. When we were trying to figure out how to do our small groups, we went to the University of Melbourne, which is a sister school of ours. And in the pre-clerkship phase, they had merely 75% of their facilitators were PhDs. They didn't have enough PhDs. They had to supplement with 25% MDs, and they apologized for that. Most schools in the US wouldn't think about having a PhD facilitated group of med students going through case-based learning. At Vanderbilt, we said, well, you're a facilitator. And actually, some of our best facilitators trying to be PhDs because they know how to facilitate and not how to engage the students in talking about this great patient they had last week that had this disease or something like that. So as a result, I think the real thing you want to do is want to be involved. If you want to be involved, think about what you may be good at. And you have to work at it. You have to get the proper faculty development and things like that to learn how to do it. I think you can get involved at any level, and we have people that routinely have done that. We have young clinicians also and young faculty. If you're a research faculty, sometimes it's harder because the one thing you have to do is establish yourself in the research realm. And to be honest, if you are in research track and as a basic scientist at Vanderbilt, as one senior associate dean told faculty, he said that no one in the School of Medicine has ever been denied tenure for lack of teaching or poor teaching. I run a great research lab and I don't teach graduate or medical students outside the lab. Even if my students hate me, but they get good jobs afterwards, and they say what a great mentor I am. So from that point of view, the problem we have is that if you're a researcher, for the most part, unless they really want to do education, there's no reason for them to do it. The clinicians, we have a lot more on the clinical educator track now. And we're really trying just to develop them, and they've been a phenomenal resource for us. Sure.
Can I pass you the microphone so the people online can hear?
What you doing? What field are you in? Okay.
The question I was going to ask you about identity, was there a point as a researcher where you had to consciously shift and drop some of your research to become more focused on being a medical educator? Because at the moment, I'm at a stage in my career where I'm torn in 3 million directions with not enough time to do anything. And I want to be a researcher and I love my research, but I also love teaching and I'm good at it. And I want to do more teaching, but I know, as you've said, that it's at the expense of my career if I focus on teaching at this point. So was there a point for you where that identity switch happened? Do I need to focus on doing more research until I'm a prof and then I'll have the luxury of being an educator? Or is there a time point for that identity to develop?
I'll be honest, I just sleep less.
That's not the answer I want. I like to sleep.
Yeah, I don't do it very well anymore. My wife gets mad. I live about 5 kilometers from school, and especially when my block's in session. And actually this week leading up, because when I travel, before it becomes very stressful to get everything done. So for the first 3 days of the week, I went back into my office about 9 o'clock at night. And if I'm not on my way home by 2 in the morning, I get nasty texts from my wife, and then I'm back in my office at 7:30 the next morning. So it turns out hard work does not burn you out. Burnout is a big deal these days. And what the studies show is working hard doesn't burn you out. It's when you can't control your own environment. I think you just have to find the things you're passionate about. When I started my laboratory, I'm a DNA enzymologist, but my chair really expected me to be a cloner. And X years into it, he basically came to me, and when I was being put up for tenure, he said, "Well, okay, you didn't turn out to be what I wanted you to be, but you've done it well. So yeah, we're putting you up." And he said, "No one turns out to be what I wanted to be." You have to do things that pay the rent. You have to, if your career path is on research and that's where you're going to be promoted, obviously you have to keep that going. I still love the laboratory. I still love the teaching. So I just do both. I wish I could tell you some great words of wisdom, but literally I just don't sleep as much. There are days when I wear a lot of hats and I have to wear them all in one day. And those are hard days because you're just kind of ping-ponging. But ultimately, if you love what you're doing, you find a way to get it done. But I will tell you that from an identity point of view, I did my fellowship at Stanford Biochemistry. When I was there were 10 faculty, 9 of which ended up being National Academy, 3 of which ended up being Nobel laureates. I worked for number 10, by the way. But of course, he was a guy named Doug Brutlog, who was starting the world's first biomedical informatics company, IntelliGenetics. Much more interested in the company than us. And I went back, and they had the 50th reunion, the founding of the department. If you ever want to feel really bad about your own career, go back to one of those. Right? I'm surrounded by colleagues that are now National Academy and things like that. That was 10 years ago. And at that time, actually 5 of the 6 founding faculty were there. Only Arthur Kornberg had passed away. They had last year, the 60th anniversary, and still 5 of the 6 original faculty were there. This one I felt vastly better about myself. Because, we had 5 Nobel laureates in the room. I couldn't touch them, research-wise. But I knew more about medical education than anybody else in that room. And that made me really proud of what I'd done. And so I had a very different view of myself with that group. Because now, yes, you're National Academy and I'm not, but there are skills I have that you can't come close to. So from that point of view, I think the identity becomes a really important part of you.
Hi, Neil. My name is Dianne, and I'm based here at the University of Otago, Wellington. Thank you so much for what it was that you shared this morning. And I don't have a question, but more so a comment. In that over time, I've been really encouraged by the increased value and recognition that is being assigned to medical educators and scientific educators as well. I'm a science researcher, a scientist, researcher person, and I came through at a time where there perhaps wasn't as much support or awareness for academics and researchers who were teaching in the academic space. And so I'm really, really encouraged to see where it is that we've come to today, and would really like for that to continue, like for that trajectory to continue on. So so I just wanted to share that.
I think it really is. I mean, there are these organizations now. The AMI meetings have 4,500 people. I am being the treasurer I am, so I'm really want to make sure a lot of people come to our meetings, because the more they come to our meetings, the better my treasury does. And so we're 3 weeks off of our meeting, and we have 634 people signed up, which looks like we're going to a record level. The ANZAP meeting last year, I think, had a very large number of people that went. So I think that these organizations are gaining speed, or they're gaining traction, and once again, there's tremendous opportunities. It's surprisingly few people that are willing to get involved in the administration of these. So, go to the ANZAP meeting, let people know who you are, run for the board. There's a real good chance there aren't 100 people running for 5 spots for the board. And it's amazing that you can step up pretty quickly in a lot of these organizations. I went to my first IAMSA meeting in 2010. And 6 years later, I was in the executive committee, and I was the treasurer, right? So these things you can do relatively easily if you want to do them. And I think it's tremendous fun. And one of the things that then you get to do is play at a totally different level. So I think that these things are definitely, there's an upward trajectory of all these things now, a lot of ways to get involved.
I'm going to ask a question now of my colleague Mark, who's Associate Dean Student Affairs. How do you think the medical students perceive being taught by scientists rather than doctors? For example, in the clinical, in the tutorial environment?
If I may, they're being taught by doctors, not physicians. The root of the word doctor is teacher.
I think the major difference, excuse me, is the thing you put on the slide at the beginning. It's really about that educator caring, preparing, engaging, being enthusiastic. And unfortunately, because someone is a physician, doesn't necessarily mean that they bring that. They may be brilliant in what they do, but the students will come and say, didn't seem interested, or I didn't really get it, what was going on, because it was just a PowerPoint presentation. So ultimately, it comes back to not just the time that they spend, I think, in the small group or in the classroom, but there's that sense that they can get back to that person. I think that's a really quite an important bit, is that after the lecture, after the tutorial, after the small group, after the clinical contact, or whatever it is, that if they wanted to ask something, they feel they could go back to that person. And it's quite an interesting little change. Can I go back?
So a bit like having a learning community and there's lots of people in it, but they've got to be really enthusiastic to be teachers. It doesn't really matter what their qualification is as such.
Yeah, absolutely. And it's more of a sort of, I guess if you ask the students, it's that feeling that about that person. If I went back, they're approachable, I'm not going to be thought to be silly, or I've made enough of connection in that small contact that I feel I can go back and speak with them. Over and over again, problems, they'll come and see me because they say, well, I didn't really want to go and speak to the module convener about it. Or I slipped up there and I didn't really, so why didn't you ask? I didn't really think that I could bother them or that they were interested.
I think what's important is someone educating me properly, right? At Vanderbilt, I will admit, 20 years ago, we had a them and us. It was the physicians and the PhDs, and we didn't get along very well. We didn't know each other very well. And one of the things, it's certainly at the faculty level, but I think also at the student level, we don't even think about that anymore. We're all in the same boat. It's a continuum. It's not a brick wall between anymore. And I think it's whoever, if you need to teach something that's clinically relevant, find the person that can teach it the best and understands it the best. And there's so many things now, like I said, if we get away from the idea that there's basic sciences and there's clinical sciences, it's one continual spectrum. And once again, tell me about the disease your patient comes in with, whatever metabolic disorder. What's going on? They should be able to tell you that. We had an MCAD case, which is a middle chain fatty acid degradation disorder. Should have been the most boring case the students ever had. And it turns out they loved it, because this is a case where it turns out that you can't do gluconeogenesis. So you have a perfectly normal, healthy baby, but if they don't eat for 12 hours, they go into a coma and die. And this is a result of about 25% of SIDS babies, sudden infant death syndrome, actually result from this. We had a young pediatrician who was one of the facilitators for the case. He got very excited because they had two MCAD. They had a family with MCAD, and they had two of their children that were routinely in for service for being taken care of. And on the one hand, it was great. She said they never really understood it before, so she was very excited and went back and told the residents about what was going on. And I thought, that's great, but I mean, at Vanderbilt, I would really hope you have some clue as to what causes the disease, not just how to treat it. But the fact is that they can learn and do it. So our students love those cases because metabolism actually explains everything. They're coming up on their psychiatry block at the end of the first year, and that drives them crazy because there's so many things they say, well, we don't understand it, and the students don't like the ambiguity. So some of these things, it works out really well. But once again, I think it's just what they're looking for is someone that can teach them. And if you can teach them, I don't think it matters. I mean, there's things that a clinician can teach them I can't, obviously. But I'm not teaching physical diagnosis. So when it comes to disease states, I think that whoever teaches it the best, it works out fine.
Yeah, just a comment on student perception from my experience is that so I'm in a department of surgery as well. So they tend to be they really just want to get into theatre and focus on things. Yeah. So I found that it's not all students, but some of them do perceive you as a bit lesser, being a scientist, particularly, being in a department of surgery. But the thing that I found made the biggest difference with that was when they would then see me interacting with the surgeons, and because we run a big research program with the surgeons. So once they saw me down in theatre or in the clinic as well and interacting directly with the surgeons, they seem to actually want to listen to you more because it's sort of you get taken a little bit more seriously then. So I think also working closely on both sides between the science side and the physician side makes a big difference in how the students perceive us.
Certainly if the surgeons don't respect you, the students won't either. And it goes the other way. Yeah, no, I think that's reasonable.
Certainly in ELM, which is our early, would be your pre-clerkship, I think the critical thing for the scientist is the clinical context. Absolutely. And that's what a lot of scientists who teach and believe they're going to be medical educators don't recognize. That they can't walk in and teach science. As you say, you teach the metabolic pathways, why in the world are you teaching this? If you put a clinical context onto it, that's when you're actually recognized as a medical educator within that environment.
I learned all my pathways as an undergraduate and as a graduate student. I learned them all, that entire metabolic chart that you put up on the wall, everyone cringed at it. I knew every pathway, I knew every enzyme, I knew every structure. I didn't remember it, didn't have any context for me. I was told by one of the older faculty years and years and years ago when I was still a biochem course, I was pandering to the medical students. And I looked at him and said, okay, you talk about your research. If you're talking to a bunch of undergraduates, you talk differently than when you talk to biochemists or chemists or physicians, right? Absolutely, I said, that's exactly what I'm doing with the medical students. And it's really true. In the days when it was a biochem course, I went back and looked, we taught 2.5 hours of the TCA cycle. Pushed every electron, went all the way around. There's no reason in the world for a physician to have to know that. To be honest, we haven't taught that to our graduate students in 20 years. When I ask my graduate students where ATP comes from, they look at me and say the Sigma catalog. They don't know what I'm asking. Literally. So yeah, we're still teaching a lot. We're giving them a tremendous amount of information. We're just putting it in the context. Put it in the context. I'll talk a little about that in the afternoon, but put it in the context of the patient, which is an important thing to do for reasons we'll talk about. But I think beyond that, it's like, I'm teaching you the sciences I think you need to know to be a good physician. Now there's the old argument, there's two arguments with medical education. How much science do all physicians need to know? And the answer is, I've never found anyone that can give you a proper answer for that. Now, when I have the cardiologist saying you can't possibly be a physician without knowing this, one of the people that was doing the pre-clerkship curriculum is a pediatric neurogeneticist, and he would say, really, you think that? So he'd go to the obstetrician and say, do you know that? And they go, well, I don't know that. And he go to the surgeon, do you know that? I don't know. They said, I guess all physicians don't actually need to know that. So we all are very centered in what we're doing. The other problem is, how do you know it works? And I can tell you with our board scores, and I can tell you about placements, but once again, am I making you a better physician? I can give you anecdotal evidence, but no one's found the metrics to look at that yet. And that's really hard, because you may be doing cardiac bypasses and you have a 95% success rate, but you're doing the absolute routine ones where the national average is 97%. You've got 80% success rate because you're doing the ones no one else will touch. That the average rate is 30%. Which one of you is a better, cardiac surgeon? The answer is, the metrics say you are, but you're actually much better. So those are hard things. Those are hard things. And as you were saying, if you put it in the context, okay, the faculty is the most creative group you have in any university, by far. And we're there the whole time. And you get that amazingly cutting edge creative researcher and you say, oh, you know, can you change the way you teach these? I've been teaching this for the last 30 years. TCA cycle hasn't changed. Why should I change my lectures? And they're incredibly entrenched. But once you get them moving a little bit, it's actually interesting. It's hard to revamp, but once you do it and you start getting different feedback from the students, it plays in really nicely, and it becomes very encouraging. You really want to be the faculty member that they hate less than someone else. And now, when we put the pre-clerkship phase together, the basic sciences were like rock stars at Vanderbilt, which was just bizarre. Because scientists have always felt a bit second class at most medical schools. We're not real, you know, doctors, quote unquote. We are actually real doctors. We're not physicians. As they said, we always feel like the brown shoes at the formal occasion. And it's really remarkable because in a lot of places now, you know, what you put together, you know, we totally revamped the pre-clerkship phase, went to a 1-year pre-clerkship phase instead of 2 academic years, and we pulled it off. And, you know, we were treated really, really well and held up as a shine. In fact, we were always ones that had to talk first to the executive faculty and things because my administration knew that we could explain it to them, whereas the clinicians in their phase that hadn't done much, you know, okay, instead of having 11 weeks for medicine, we're going to have 8 weeks now. We'll do the same thing. It's like, that's not going to cut it. Because Dianne here is the art of facilitation.
Okay, so I'm going to say thank you to Neil now for this talk. It's been really interesting hearing about his view about what is the modern role of the medical educator, and we're going to hear some more about him later, from him later, not about him. And then the workshop this afternoon. So I hope you've all been able to take away, all the scientists in the room, some idea that you do have a role in medical education. There's lots of roles out for you there. There's leadership roles out for you there. We've got some good examples in this medical school already, like Peter Larson, you know. He's a fantastic example of how you can be a scientist and be a medical education leader. And it's about taking that first step, isn't it? About seeing yourself in that way and that identity that you've talked about. So thank you very much for introducing the idea of identity and scientists adopting the identity of a medical educator. So hopefully we'll see most of you at 1 o'clock, and then at 2 o'clock we're just going to have lunch now in the cafe. Right, thank you.